Very good afternoon and a very warm welcome to NITRD, Central TB Division, National Task Force Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to extend heartfelt welcome to our esteemed DDG ma'am, Dr. Shobini Rajan, to the directors and teams from NIRT and NTI, state TB officers, directors of STDC, faculty members from medical colleges, district TB officers, medical officers, and all other distinguished participants, a very warm welcome. I am Dr. Neeta Singla. I am the Nodal Officer for DRTB Center at NITRD. It is my honor to introduce the faculty of NITRD. On my right is Dr. Rupak Singla. He is consultant in the Department of TB and Respiratory Medicine. On my left is Dr. Saroj Meena. She is a pulmonologist at NITRD. Today, I have the privilege of welcoming our new DDG Madam, Dr. Shobini Rajan. Madam is from Central Health Cadre and has been in NECO for more than 2 decades. Madam has recently taken over as DDG TB in the Central TB Division. She comes with more than 3 decades of experience in the field of HIV and AIDS. She has experience in laboratory medicine and blood transfusion services in the government. She's a skilled professional in public health administration, engagement with non-profit organizations and communities, national health program development, and strategic information systems and health system management. We welcome you to the NTP family, ma'am. Ma'am, little about our clinic. We started Difficult to Treat TB clinic in 2020. Since then, we have been holding these clinics regularly every month. Here we discuss one difficult case from the periphery where they have found it difficult to manage the case. So we try to learn from each other's experience. We also disseminate the national guidelines from this clinic. These clinics are attended by all the officials of NTP, that is DTO, state TB officers, medical officers, faculty from medical colleges, etc. This model has been very successful and has expanded to all the states in the country. And now every state is doing their own difficult to treat TB clinic. We at NITRD have tried to handhold these clinics to bring up the quality of these clinics. I now welcome our director, Dr. Upasna. Dr. Upasna has a vast experience in TB and HIV and internal medicine. We request Dr. Upasna to deliver her remarks.
Thank you, ma'am, for that kind introduction. And I begin my 2-minute talk by welcoming Dr. Shobini Rajan. I have worked with ma'am for so many years. I've known her for so many years, and she has done amazing work in laboratory medicine in HIV and TB. Laboratory, as you know, is the backbone of any medicine that we do, and any medicine that is practiced. Any patient that is seen is as good as the laboratory backup that you get. If you don't have any laboratory backup, you actually cannot see a patient properly. Welcome, ma'am. I'm so happy to know that you are a DDG. And now go on to the speaker. I see that the case is being presented by Dr. Gautam Ram Karthik. He is from the Madras Medical College. And the national expert is Dr. Digambar Behra, who is our respected former director and an inspiration for all of us. And hi, Dr. Singla and Dr. Neeta and Dr. Saroj. Today, the case is on ADRs of the BPALM regimen, which is, I think, a very, very, very important topic because BPALM is relatively a new regimen. People are still learning about it. And whenever you start a regimen in the field, it's always the ADRs which become an issue. And today's case is also interesting. It is a case of cervical lymph node TB. And with another warm welcome to our DDG TB, I hand over the mic to the podium.
Thank you, Dr. Upasna. Now I request our DDG Madam, Dr. Shobini Rajan, to please give her remarks.
Thank you very much, Dr. Singla, Dr. Upasna, all the esteemed people who have joined this session. I'm told this includes state TB officers, STDC directors, nodal officers at district DRTB centers, medical college faculties, WHO consultants. And I do understand that this is a difficult to treat TB clinic, so you would probably have the cream of all those who use their discretion to treat TB patients in this gathering today. So I'm really honored to be here today. And thanks for the warm welcome accorded to me. As you can see, I'm not really a TB expert, but I do come with about 3 decades of experience of working in the public sector at different levels of um, facility, that is the hospital, the state level, and the national program. So, at the outset, I'd like to congratulate NITRD for taking this lead and successfully running a difficult to treat TB clinic in collaboration with the national program. And I'm told there is a national task force as well. And this is not just something that you're doing occasionally, it is something you have consistently done for the last 5 years. So I'd like to personally thank Dr. Ashok Bhardwaj and his team from the National Task Force for providing guidance and support to the difficult to treat, National Difficult to Treat TB Clinic. I'm sure this would also have some kind of an acronym, and I'm still getting used to the acronyms in the program. So, since there are always some complex cases where the DRTB center committees are not always able to arrive at a conclusion, there is this mechanism within the program and within the NITRD to take guidance from national level experts. And I'm also told that at district level, there are difficult cases which require guidance from experts. And as per the National Guidelines on Management of Drug-Resistant TB 2024, the District DRTB Center Committee should seek guidance from the Nodal DRTB Center Committee. And in some cases where there are limitations, then the expertise at state level or national level is their opinion is sought. So the guidelines and the guidance that the Central TB Division has released in this regard, I'm sure all of you all must be familiar with that. And I do see that this kind of a mechanism is really important when we are going to the last mile towards TB elimination and towards also building capacities across the board for not only doing the routine work of managing the easy cases, but also learning from the difficult cases and disseminating such a learning to all those who are concerned. So, NITRD has always been instrumental in supporting the program activities, and I think you have a Manage TB India app which helps the clinicians to decide on suitable treatment based on DST results. You have supported national guidance document on surgical care for TB patients and have been a part of the MBPOL study, which gave learning and helped the program to roll out the BPOL regimen. And of course, you are practically leading the technical expertise as part of the National Technical Expert Group under NTP. So I really look forward to listening to this session and learning from all of you. And I seek all your support towards taking the program forward. Thank you.
Thank you so much, ma'am. Thank you for your kind words. Today's clinic is today's case is being presented from state of Tamil Nadu, and we have Dr. Gautam Ram Karthik who's presenting the case. He is assistant professor in Department of Respiratory Medicine from Madras Medical College. The state expert is Dr. Vinod Kumar. He's director professor, Institute of Thoracic Medicine in Madras Medical College. And our national expert is none other than Dr. Digambar Behra sir, who is a Padma Shri awardee and a professor emeritus in Department of Respiratory and Critical Care and Sleep Medicine at PGI Chandigarh. And our clinic expert, the DT3C expert, is Dr. Rupak Singla, who is a consultant in Department of TB and Respiratory Medicine. So over to Dr. Gautam for his presentation.
Thank you, ma'am. So, is my screen visible, ma'am?
Yeah, it is. Yeah, can you enlarge the slides? Yes, it's done.
A very good afternoon to one and all. I would like to thank the organizing committee for this opportunity, and I would like to thank my professor, Dr. Vinod Kumar sir, for this opportunity again. So the BPALM regimen has transformed the management of drug-resistant TB by offering a short and highly effective all-oral treatment option. However, in real-world practice, the treatment success is often determined not by the microbiological resistance failure, but by the ability to recognize and manage the adverse effects. I think our case presentation today is significant based on this point. So our patient is a 21-year-old female, an architect by occupation, presented the swelling on the left side of neck associated with pain. There was no history of loss of weight, appetite, fever, no constitutional symptoms, no history of contact with TB. There was no known comorbidities, no past surgical history. And on clinical examination, there were multiple firm, discrete cervical lymph nodes of level in the level 2 to 4. The clinically it measured about 3 by 2 centimeters clinically. No other lymph node groups were involved. So on examination, going forward for further investigations, the USG neck revealed cervical lymphadenopathy, and we proceeded with the USG guided core biopsy from the lymph node, which was subjected to gene expert and biopsy and liquid cultures. The gene expert turned out to be detected Mycobacterium tuberculosis in low levels with resistance being detected. And on histopathological examination, showed necrotizing granulomatous inflammation, and the FB stain was positive in that. CT chest revealed no significant abnormality. This was all during the February month. So this is the USG neck showing enlarged cervical lymph nodes adjacent to the left carotid artery, the largest measuring 2.8 by 2.4 centimeters. And the histopathology showing it stained positive for FB on the AFB stain and the necrotizing granulomatous lymphadenitis. So, despite the gene expert being resistant, but the levels detected were very low, and being a possibility nature of the disease, we decided to wait for the culture reports and started the patient with conventional ATT along with steroids at 0.5 mg per kilogram body weight. Going forward, during the mid of March, the drug susceptibility liquid culture, MIGIT SIRE panel, and 10 drug panel reports showed sensitivity to all the first-line drugs, isoniazid, rifampicin, ethambutol, and the 10 drug panel showed resistance to pyrazinamide alone. So we continued the conventional ATT, which was tolerated by the patient along with steroids till this point of time. The patient was under close monitoring. The patient was tolerating the conventional ATT regimen. So this is drug susceptibility testing panel reports. On the left is the SIRE panel showing the sensitivity patterns to all the first-line drugs and streptomycin, and subsequent 10 drug MIGIT DST panel showing resistance only to pyrazinamide. So on follow-up during the third month in April 22, in view of increase in size of the lymph node mass, a repeat USG was done, which showed significant increase in the size of the nodes, and the nodes now enlarged to 4 by 3 centimeters with infiltration into the adjacent left sternocleidomastoid muscle. So we decided to go ahead with the excision biopsy of the lymph node, and it was done on May 15. And the abscess drainage on the left side of the neck, cold abscess, was also done. Pus and was sent for culture and sensitivity and MIGIT, and the tissue was sent for HP and gene expert. The gene expert here again detected Mycobacterium tuberculosis. The levels were high, medium this time, and resistance was detected in this. The HPA again showed necrotizing granulomatous inflammation, which stained positive for AFB. So the MIGIT tissue which was sent did not grow in AFB. The report was returned on 27th June. So meanwhile, the patient was continued on the drug sensitive pattern. Conventional first-line ATT drugs. So in view of the poor response and enlarged size of the lymph nodes and the gene expert reports, we went ahead for a pre-treatment workup of the drug-resistant tuberculosis and repeat evaluation, baseline evaluation. The chest X-ray was again repeated, which showed no significant abnormality. The cardiological evaluation showed no structural defects, along with the ejection fraction was normal and there was no associated pulmonary hypertension. Thyroid profile electrolytes were normal. HB at baseline was 10.2 gram per deciliter. So the pre-treatment workup, multidisciplinary consultation was obtained, and the DRTB regimen, BPALM regimen, was initiated on 27th June. So so we went ahead and started the BPALM regimen, bedaquiline, pretomalin, amoxicillin and pyridoxine was administered at 100 milligram. So going forward, immediately after starting the BPOL regimen, the patient developed significant upper GI intolerance. She presented immediately with complaints of severe epigastric discomfort, nausea, and vomiting with the starting first dose of the regimen. It was temporarily associated. It started within 2 hours of ATT drug intake. It was clinically interpreted to be drug-related acute gastritis, and the patient was counseled. And we took a conservative approach towards this and shifted the dosing schedule. We shifted the drug intake from morning to night, along with as needed pantoprazole for the patient. So no additional drugs were needed for this. The patient was showing good tolerance to the timing. After timing modification, she remained compliant over the course of the treatment, and no recurrence of the GI symptoms were followed after just shifting the dosing of the schedule of the drug. So regularly the patient was monitored further. So on the follow-up, during the first month of the therapy, the patient developed multiple adverse events, which is not uncommon with BPALM. The most objective abnormality was anemia, which was detected on 10th of July on the first month follow-up. The hemoglobin dropped to 9.3 gram per deciliter. In addition, the patient reported multiple constitutional and subjective symptoms, including yellowish discoloration of the teeth, diffuse hair loss involving the scalp and both the lower limbs, and depressive symptoms. So when we evaluated the anemia, there was no red flag features like bleeding, no evidence of melena, gum bleeds, no evidence of any hemolysis, no hemodynamic compromise. This allowed us to categorize the anemia as mild and drug-related. So similarly, hair loss and tooth discoloration were regarded as non-serious adverse effects with anti-TB drugs, and depressive symptoms were assessed in the background of the new drug-resistant TB regimen, the longer duration of treatment required, and the psychosocial factors. So importantly, there was no functional limitation for the patient, and no indication of severe drug toxicity at this stage. Hence, we took a conservative approach, and no drug was interpreted at this point. For anemia, it was felt in the mild category. No transfusion was indicated. Only dietary advice along with nutritional optimization was provided. So for hair loss and teeth discoloration and depressive symptoms, the cornerstone in management remained detailed counseling. The patient was reassured regarding the reversibility of the regimen, reversibility of the symptoms. She was informed about the expected timeline of a reversal of the symptoms and counseled on the importance of continuing the therapy, and drug adherence was maintained. So this was very important. And on follow-up in the subsequent months, the hemoglobin on 14th October improved to 10.5 gram per deciliter without any pharmacological intervention. The patient was under continuous monitoring and follow-up. So going forward, in the 4th month in the late October, the patient developed early neurological symptoms, predominantly sensory in nature. Patient presented with complaints of mild tingling and burning sensation in both the lower limbs. It was graded as one mild peripheral neuropathy, likely attributable to linezolid, given the timing, the clinical pattern, and the known toxic profile of linezolid. So in keeping with the guidelines-based management and on follow-up, the patient had pain also developing in both the limbs. So it was graded as grade 1 to 2, and linezolid dose reduction was in the patient has completed already 9 weeks of therapy. So linezolid dose was reduced from 600 mg to 300 mg once daily, along with close clinical monitoring. So we also supported the management with neuroprotection and symptom prevention rather than aggressive intervention. Neurotropic supplementation was initiated with the intramuscular methylcobalamin and neurokine tablet containing again methylcobalamin and L-aspartate. So the patient was kept under close monitoring for symptom progression and functional limitation, and followed up for any further dose modification. So by the end of the 4th month, we also disease response to the drugs was also assessed. Clinically, there was no palpable lymph nodes by the end of the 4th month, that is in the reduction in the radiological USG. We noted the reduction in the lymph node size by the end of the October, the largest lymph node size being less than 2 centimeter in the same level, and we demonstrated a good therapeutic response to B-palm regimen, which strongly supported the decision to continue treatment despite manageable adverse effects. So, okay. Further, despite the dose reduction and supportive therapy, the patient experienced a clinical worsening of her neurological symptoms, progressing to moderate to severe grade. The patient at the late November had functional impairment. She had pain in walking short distances and worsening tingling and sensory symptoms in both the feet. At this stage, a neurological consultation was obtained, and the decision was taken to continue the regimen cautiously with linezolid maintained at 300 mg pending specialist consultation. So the neurological evaluation confirmed the drug-induced peripheral, linezolid-induced peripheral neuropathy. Nerve conduction studies and electromyogram demonstrated findings consistent with motor predominant polyradiculopathy, and there was a strong temporal and clinical correlation with linezolid exposure, reinforcing the diagnosis. Importantly, no alternative neurological etiology was identified, allowing us to confidently attribute the toxic profile to linezolid and continue the management of the same. So the neurologist, after neurologic consultation, she was advised injection methylcobalamin 1500 microgram once every 15 days. Pregabalin was administered, and clonazepam 0.25 mg once daily. Along with this, with the improved clinical assessment, and the patient was in the 5th month of her therapy, the close clinical follow-up with neurology was continued, along with the patient being on 300 mg linezolid. So the patient finally completed a regimen 6 months duration, 26 weeks of a B-palm regimen on 28th December 2025. At the end of the treatment, the USG neck, there was clinically no nodes palpable, and the USG neck showed less than 0.5 mm lymph nodes that was present, and the patient was branded as a microbiological and clinical cure was obtained, and we are able to manage the ADRs without compromising the treatment completion. To summarize, a patient after starting the B-palm regimen had presented with these major side effects, including gastritis, which was present immediately after starting the regimen, which was managed conservatively, anemia, hair loss, and depression, for which detailed counseling and graded response was, monitoring was key, and peripheral neuropathy, which persisted and progressed despite reducing the dose of linezolid to 300 mg, and the patient is being continued to monitor for the same. So, thank you. Thank you for the presentation, sir.
Yeah, thank you, Dr. Gautam. Very well presented.
Yes.
So now I open the forum for any questions that you may have regarding the history. Yes, Dr. Rishi, please.
First of all, good evening to all of you, my seniors, my mentors, and the chairperson, the teacher persons also. My my question is regarding since this case has very well vital the level of the linezolid toxicity reached to the level of up to phase 3. The concern is that in such cases, surviving lymph nodes, we usually don't have after 1 month of treatment, we don't get the samples because the size of the lymph nodes is also decreased, and the pus also doesn't come. So how can because we only do for the
Dr. Rishi, sorry to interrupt. आपकी आवाज बिल्कुल clear नहीं आ रही है. We are not able to.
Yeah. Just one minute, madam. Just yeah. Madam, the concern is that since tuberculosis, the cervical nodes usually the size is slower. Sound is not available.
No, sir. It is not at all clear.
I think 2 devices are.
Can you write your question on the chat box, Dr. Rishi?
Sure.
Thank you.
Maybe you have two devices there logged in the same room.
Echoing actually.
Okay, so meanwhile, sir is writing down his question. Meanwhile, if somebody has a question, they may ask.
Ma'am, there's a question in the chat box. When they started the drug sensitive treatment, why Visclone was started from the beginning?
Dr. Gautam?
So,
The reason for starting the Vice loan in the case of the lymph node.
With initially, we started Wise Loan because of I mean, the response, the drug penetration usually will be better in case of Wise Loan. The conventional ATT with the drug penetration will be usually increased when we add an anti-inflammatory therapy. So for that reason, we added the Wise Loan for the patient.
Dr. Singla, would you like to add something?
Yeah, usually seen whenever we have lymphadenopathy. For cervical, usually we are not considering steroids, but for mediastinal lymph nodes, especially the larger one, we are likely to sort of reach the tracheobronchial tree and may cause obstruction also. Here, along with the ATT, steroids should definitely be considered. Otherwise, by and large, for cervical, we may not give the steroid. So, I think that their practice may be followed that their media larger enough and compressing the media channel structures, there it should definitely be considered.
We noted that in the first USG, we noted the left carotid artery was adjacent and we thought the inflammation might be helpful to the patient.
So basically, there are many mixed of studies also where Vicelone has been used in cases of lymph node TB. I think just in order to reduce inflammation, like sir has cleared it now. But usually we do not prefer in TB lymph node. Sir, there was, I think we haven't seen chest X-ray finding in this patient. Was there any mediastinal lymph nodes also?
No, ma'am. CT chest was done at the baseline, which was completely normal. No lymph nodes, no parenchymal or mediastinal abnormalities were noted.
So there's one question, can I ask? So in this case, like towards the end of the treatment, we've seen the patient develop moderate to severe neuropathy. So despite that, we continued lenalidomide, but the patient tolerated, patient got cured, so our purpose have solved. So how is the patient doing now? Is she still impaired? Disability is still there, or she's improving or getting better? The neuropathy part.
So at the end of the follow-up, the patient still has complaints of pain. She's able to walk, ma'am, but she complains of pain, probably improving with the 1 month of the after neurological consultation and management. She's having mild symptom improvement, but she's not fully developed. It's still grade 2 to grade 3. She's able to walk, but she is having mild pain while walking shorter distances.
We also prescribe the patient for physiotherapy, like this for this neuropathy pain. Is she taking any kind of physiotherapy?
No, ma'am. No physiotherapy as it was advised, Shili.
Okay. So there's one question in the chat box. What could be the reason for yellow discoloration of teeth?
I want to emphasize the newer. It was not reported, but the patient typically had. We want to emphasize the newer side effects also apart along with the noted side effects. The reason being unknown, ma'am, but the patient typically had discoloration and it persisted during the management.
So now I think it must be getting better after stop of treatment.
Yeah, you see this bluish discoloration of the teeth is it has been described with rifampicin as well as with linezolid. And usually they say once the treatment is over, it subsides by itself. And in some cases they take the opinion of dentist and they may do superficial cleaning. So otherwise, usually only counseling is required, and as the treatment is stopped, this bluish discoloration fades up.
Sir, Dr. Rishi has written his question in the chat box. He's saying that in cases of tubercular lymph nodes, we all must have encountered that this lymph node size decreases with due course of treatment. So how to so like at the end of the treatment, we just can say that there's a completion of the treatment because there is no site available for sample collection, and we declare them to be cured on the basis of clinical improvement and lymph node decrease in the lymph node site, radiological basically. So yes, I think we agree with that. That's the only thing we left with lymph node cases, if the patient improves, then at the end of the treatment, we can never prove them through a microbiological confirmation whether it's cured or it's converted, but it's always through the radiological improvement along with the clinical improvement in the patient.
I think the question is not about whether to call it like whether is patient cured or not, but maybe it's the definition under the program. Because under the program, we say cure only once we have demonstrated the negativity at the end. So maybe that's their query where it should have been treatment completed and not cured programmatically.
Okay, ma'am. Okay, ma'am. Okay, ma'am.
Right. Okay. So are there any more questions?
No, ma'am.
Hello.
Yeah,
Hello,
there's one
ma'am.
question.
Am I audible?
Yeah, sorry. Yes, sir.
Yeah, ma'am. I am from Chandigarh. I am a pediatrician here.
Yes,
So
sir.
my question is regarding tubercular lymphadenitis in children. Many of the times we are not able to see AFB or even the CB-NAT we don't get. And the thing is that we have to rely on the pathological reporting, which is most of the times not very consistent with tuberculosis. They will report it as like granulomatous inflammation, but we don't see the typical caseation, necrosis, and the Langerhans giant cell. So it's rarely reported. So would you advise that what could be the further line of investigations in such cases, ma'am?
Thank you for your questions. I think we are joined by Dr. Virinder Singh, who just wrote a remark. So, Dr. Virinder, would you like to answer the query?
Thank you, Nita, for asking me. Unfortunately, while I was writing, I could not concentrate on what gentleman was saying. Could he repeat it?
Dr. Shashi, could you repeat your question?
Sure, ma'am, sure. Good afternoon, sir. This is regarding pediatric tubercular lymphadenitis. So most of the time, we are not getting AFB positive in the smears, or the CBNet also is not like it does not come positive. And we are left with the reporting by the pathologist, which is very rarely is a typical tubercular granuloma, like the caseation necrosis and the Langerhans giant cell. I have not seen it for quite some time now. So, but we are strongly suspecting some tubercular etiology here. So, what could be the other supporting investigations, sir, in such cases? Just wanted to know you to highlight on
So
that.
supportive investigations are of limited use because they are indirect evidence. At best, you can get a MONTU or a TST positive, which only suggests infection, not disease. So that's hardly a support. So what you need, because one of the differentials would be Hodgkin's lymphoma, if you're getting a multinucleated giant cell there. So it is always better to go for a biopsy rather than going for if there is significant lymphadenopathy, it has to be accessed. So we can repeat aspiration and send for another NAT, or go for excision biopsy, and from that tissue you can do NAT as well as the histopathology.
Okay.
Thank you.
Thank you, sir. Thank you so much.
Actually, here I would like to share our experience at our NITRD. You see, I know the difference in the size will be there in the adults, but our positive rate by CBNet for lymph nodes when they are sort of tubercular is very, very high. We are able to, maybe I can say with confidence, more than 80% of the time, once we have significant lymph nodes and we do a good FNAC, we find the CBNet result to be MTB present and either sensitive or resistant. Well, Dr. Vrinder also said initially, if you are thinking strongly of TB, then another aspiration, FNAC, can be tried easily. It's not a very invasive investigation, can be done easily in the periphery also. And it gives you the answer, well and good. Otherwise, as Dr. Vrinder said, the biopsy and other things to be considered. But in adults, we have very positive output of the FNACs for detecting tuberculosis.
Yeah, so I would not say 80, but in our hands or studies done by us, we are able to see in about 40 to 50% of the patients that we are able to get. Particularly when you get pus, you're more likely to get it. If you only get tissue sap, then the bacillary load is much less, and then sometimes you get, sometimes you don't get it.
Right. So there are two comments here which relate to each other, where Dr. Vrinder Singh has asked that there was no RIF resistance in the first sample that was collected for this patient. However, after 2 or 3 months, when the repeat gene expert was done, it came out RIF resistance. So is it a acquired resistance? Do you think any comments on that? And there's another question by Dr. Rishi, which says, could it be reactive lymphadenitis? And then in continuity, Dr. Ravi Kumar has asked that, what is the role of culture in such cases? Like, what should we do? So, I think Dr. Vinod, sir, the state expert, sir, are you there?
Yes, sir. I'm here, ma'am. Yes, ma'am.
Right, sir.
Actually,
Welcome, sir. Welcome,
yeah,
sir.
yeah. So yeah, thank you, ma'am. Actually, we had a couple of challenges in this case. Actually, the initial case, what happened was the gene expert was showing RIF resistance, but the patient actually, she had no exposure. She actually came from a family of doctors. They were very reluctant. They were not willing to accept the diagnosis of DRTB. We had a lot of challenges in this case. That's why we had to start this DSTB's regimen initially, and we waited for the culture, but the culture came as negative, and it was showing RIF sensitive. But then after that, in the initial 2 weeks, the patient had the nodes completely resolved. But then it was like a fall and rise phenomenon. The nodes started coming back, and then there was a lot of this cold abscess developing, which is at that point we approached an NART with another repeat sample. And since the gene expert was showing negative, was showing RIF resistance, we decided to start on Bipalem regimen after taking expert consultations from Center of Excellence, Tambram, and NART. We had discussion with all these people, and then we started the regimen. And like Gautam pointed out, during the regimen, we had lots of challenges. There were a lot of side effects, but then we kept counseling the patient, and somehow we were able to complete the regimen. So there was an initial discrepancy in the midget and the gene expert report, but then the final gene expert was definitely showing a resistance, and the clinical behavior was also like a resistance TB in this case. Yeah. So we just wanted to highlight the challenges which we faced in this case.
There are two questions which are related actually. So both the concerns are key in these cases, DPTB cases, whether it's fluid or TB lymph node. The sample, usually when we do the CVNet, is most of the time it tells us this detected load is very low. So how to go ahead with it in these cases to rule out rifampicin resistance, because we always say when it comes to be very low, we repeat the sample. Sir, would you like to take this question or shall I answer?
You see, this is always a challenge. We have EPTB where the sample can be easily obtained, like the cervical lymph nodes, or I can say even pleural effusion where it is not very difficult to obtain a specimen. And we get the report MTB detected very low, rifampicin resistance detected. Then you are really in doubt what is to be done. So here there can be two scenarios where the clinical probability based on the past history of treatment taken, history of contact in the same family of MDR-TB, these things they also help. But for easy access, like I mentioned about the cervical lymph nodes or pleural effusion, it is always better to repeat. And if on repeat also, even if it is very low with rifampicin resistance, we should treat the patient with rifampicin resistance. Now the challenge comes like CNS TB or a mediastinal lymph node where EBUS has been done and the sample has been obtained, or bronchoscopy has been done and the ball has shown MTB detected very low, and then there is a rifampicin resistance. So here sometimes, rather many times, we are not able to repeat. So again, we go back to the clinical probability. In case in this situation, the clinical probability is very high for the drug resistance, we tend to treat the patient as a case of drug resistance, especially you see in the CNS tuberculosis. Here we cannot afford to put the patient in the like a drug resistance case as drug sensitive or drug sensitive case as drug resistance. But I would say that in CNS TB, it is better to repeat the CSF and then be on a firm ground from the beginning whether we are treating drug sensitive or drug resistance. And fortunately, the probability of having a positive result with CSF is high. That is, the sensitivity of CSF for detecting MTB is high. So it is better to repeat in cases of CSF and then take a call, and always keep in mind the clinical probability also. And I think as per current guideline, it is mentioned that even with MTB low rifampicin resistance, we need to repeat. But this is my personal opinion. I may be right, may be wrong. that in what we see in the clinical practice, most of the EPTB samples are either low or very. And in significant number of cases, we are not able to repeat this specimen, especially like the bronchial lavage or the mid-SM lymph node where the EBUS has been done. So I think if it is low and then we find resistance and with a possibility that we are not able to repeat the sample, there is a high clinical probability, better to treat them as drug raised.
Thank you, sir. So there's Dr. Gautam, there's one more question in the chat box which says that in the repeat sample, when we did the CBNet in the month of May, the CBNet detected rifampicin resistance and the load was medium, but the culture was negative, came out to be negative. So what could be the reason? To my knowledge, it could be the sample technique, the type of sample we have taken. Usually we give the better sample to the CBNet reporting. And the area which we hit while doing the FNAC could also affect the culture growth. Yes, doctor.
Second time it was the excision biopsy. The patient was nodes were excised and the pus was sent for a midget, ma'am.
Okay.
So there might be some discrepancy with the tissue gene expert, which was detected the Mycobacterium tuberculosis, and the pus culture was sent for the midget, which showed no growth. So,
Dr. Vinod, would you like to add more to the case? Someone has asked that did you increase the duration of the treatment from up to 39 weeks?
No, ma'am. Actually, this case, actually, the patient went in for a severe depression. She was a young girl. So what happened is there are some side effects which we were not aware. Like Rupak Singla sir was saying about this teeth discoloration. This is the first time we have actually seen this teeth discoloration in these patients. And the other thing was the hair loss. Like in a patient on chemotherapy, she started losing hair like anything for a young girl, and that too from an affluent family. These were all challenges for us, and taking her along for this 6 months itself was a big challenge for her. So these are things in the program which we should look after. We also wanted to extend the treatment, but then, they come from a family of doctors and they were very reluctant. I'm just keeping them on follow-up still. She has only recently, she has just stopped the medicines, ma'am.
Gautam, here, I think regarding this question of extending the treatment to 9 months, maybe you can clarify that once we reduce the dose to 300 milligram of linezolid, how long was it given, the 300 milligram?
Total, the duration
This was around a month, sir. Only in the last month of treatment, we had to reduce the dose.
Yeah.
So almost the 5 months she had completed, actually. She completed at 600 milligrams only. So only in the terminal part, last 4 weeks or so, we had to reduce the dose here.
Yeah, you see here, strictly going by the guidelines, strictly if you go by the guidelines, you have to reduce the dose to 300 milligram, then we extend the treatment to 39 weeks. But I agree with you that only in the last, suppose, 3-4 weeks, then it becomes difficult to take a decision. But strictly by the guidelines, once we have to reduce the dose of linezolid to 300 milligram due to any ADR or any other reason, then we may extend the treatment to 39 weeks. That is what is mentioned. Although in your case, it was just hardly 2, 3, 4 weeks left, so you may have taken a call, which is okay, acceptable.
Ma'am, there's one more concern which Dr. Brenda sir have already written down about it. The patient was initially DSTB and later become DRTB. So what could be the reasons for the acquired resistance in this particular patient and in general also? Varinder sir, would you like to take this question?
Thank you, Dr. Shimina. One of the possibilities could be a heteroresistance, but then culture was phenotypically, we also had a genotypic resistant pattern, sensitivity pattern on the culture isolate. So that is not by proportional method. There, that heteroresistance should have been picked up. So it's very difficult to say because acquisition of drug resistance in possibacillary disease is somewhat which is very, very rare. So I would bet perhaps on heteroresistance in this case, but I don't know what Dr. Rupak thinks about it. Thank you.
You see, as I noticed once the case was being presented, the first result of CBNet in February was the RIF resistance present. And subsequently, the culture did not show rifampicin resistance. But when the second, after 3-4 months, when the second FNAC was done, it again showed rifampicin resistance. So actually, the patient was on rifampicin resistance, but somehow on culture, this was not detected. So that is the case. So it was from these two reports at the beginning of treatment and in the during this the repeat CBNet, we can presume that from the beginning the patient was having drug resistance.
Yeah, so possibility of a heteroresistance where they were partly sensitive and partly, and we were perhaps able to culture only the sensitive one by chance the first time, and they were the predominant population, and therefore the resistant one was missed, is a possibility in the culture sample. So it's that's a hypothesis, a conjecture. I don't know how compartmentalized these bacilli would be in the body as to sensitive and resistance. Doesn't look likely, but I am struggling to find an answer to this.
That's true.
STDC West Bengal has raised their hand. Any question?
I have no question. I have just few comments. Actually, we follow 1% LCD proportion method. That means that out of 100 bacilli, if more than one becomes resistance, that will show resistance in phenotypic test. That is the for 1% proportion test. So if it is a heteroresistance case, then we should consider that it has become sensitive. Basically, what is the thing? The phenotypic test is not very much reproducible. If there is a 1 microliter inoculation is given to the broth, there is chance of sensitive. It is not very reproducible test. Even concentration of drug preparation give you resistance is sensitive. So I think the genotypic test what we have done, that is considered to be the final.
Right, sir. Thank you. We are joined by Dr. Behra, sir, who is the national expert for the day. Dr. Behra, sir, any comments from you?
Yes, thank you, Nita. I think a very nice discussion and all the points are taken care of, except I'll have 2 or 3 pointed comments. One about I think the why within 2 months it turned out to be resistant, rifampicin resistant. That is a question that possibly some answer has been given, but I don't know how much why the steroid was given. That point was already raised, and that is discussed. Except in certain situations, we don't give usually steroid in cervical lymphadenopathy. So that is possibly was not warranted in this case, and I don't know how much the use of steroid will be responsible for getting a second time getting a resistance. That may be a matter of conjecture, but I think that may be one of the important contributors one should see, apart from the heteroresistance, which has already been told. Then so therefore one should be very careful when using steroid, particularly in case of tuberculosis, except any case of tuberculosis, except in certain conditions where steroid is indicated, that we know maybe in some situations of CNS tuberculosis, some case of pericardial effusion, and so on. This is one comment. The second comment about the toxicity of the BPAL regimen of the linezolid, I think that is very well discussed and very well managed, I should say. Usually the peripheral neuropathy at this stage, I do not know how much will be the recovery, but maybe she may or she may not recover even completely from the peripheral neuropathy. But otherwise, it is a very interesting case, particularly the fast getting sensitive and then getting resistance. I do not know whether there was lab issues or the explanation is not very straightforward. So that is what is the interest thing for this particular case. Yeah, that I think these are the two specific comments I wanted to make.
Thank
They
you.
have discussed the case very nicely.
Yeah. Thank you, sir. Are there any other questions, comments?
Please, I am from IL Kolkata. Just
Yes, sir.
want to mention one thing, that we have got the SIA report that is come to be sensitive. Now the question comes, how this phenotypic test was done. That means there is a liquid culture was done from where that SIA test actually been done. Now, in case if it is a heteroresistance, then what happens in liquid culture? The drug resistance bacilli will grow slowly rather than the drug sensitive strains. So in liquid culture, what happens when the audiovisual signal gives positivity, will get most of the drug sensitive strain, and from that the phenotypic test was conducted. As it is not a solid culture, we cannot isolate the colony of drug resistance and drug sensitive colony. So in the broth, we'll get mostly the liquid drug sensitive colonies. And from there, the phenotypic test was conducted, and that's why we got mostly all the sensitive pattern in phenotypic test. Thank you.
Thank you, sir. Are there any other questions, comments? So, Dr. Singla, can we have your final comments, please?
Yeah, first of all, I must thank the team from Madras Medical College, Dr. Gautam, Dr. Vinod, for choosing this case and presenting this case. I think as we are rolling out the BPLM regime in the country, and I'm told almost 18,000 patients have been put on this regime by now. As in any other DRTB patients, the management of adverse drug reactions appropriately and maintaining the regime to have its best efficacy is always a challenge with any doctor treating these cases, and especially in the periphery where the expertise is limited, the investigations are limited, managing such cases becomes all the more important. So just to brief in 2-3 slides about this management of these in a particular reference to this case, that initially the patient had gastrointestinal symptoms in the form of nausea and vomiting. It is very, very common to have this, and almost any drug can cause this. So one thing is of course, the symptomatic treatment, the counseling of the patient. Sometimes we split the dose into two. We give the drugs after food, and these 7, 8, 10 days, these things, they subside. But one thing we need to remember is whenever we are giving bedaquiline containing regime, then simple metoclopramide like Perinom is very common name for this. It should be preferred. And the other commonly used drug like ondansetron, it should be avoided because the ondansetron with bedaquiline can cause QTC prolongation. Coming to this bluish discoloration of the teeth, it is not common at all, as Dr. Gautam, Dr. Vinod also mentioned, but it is known to be associated with rifampicin or betamethasone. Usually nothing active is to be done, and with time, as the treatment is completed, it disappears. And sometimes because of cosmetic reasons, some patient, they want to consult the dentist, and only superficial cleaning is required, and it goes away. Into myelosuppression, it's always a big challenge, especially in the periphery, because it is whenever the patient has the patient presents with falling of the hemoglobin, then it becomes very worrisome how to manage these cases when the investigation facilities are limited. So keeping in mind as per our national guidelines, we should not start the BPLM regime if the hemoglobin is less than 8 gram, or the neutrophils count is less than 750 per cubic millimeter, or platelet is less than 25,000 cubic millimeter. Of course, you see in India, malnutrition is so common, or the anemia of chronic disorders, that many patients are likely to have hemoglobin less than 8 grams. So the program advocates that in these situations, consider giving blood transfusion and other therapy. And in case you can increase hemoglobin to 9 grams or more, then the linezolid regime can be started with a strict follow-up and a watch on the hemoglobin and the CBC. If you find after putting on treatment and with this blood transfusion, the hemoglobin improves, and then we can reintroduce in a low dose of linezolid with 3 milligram. We monitor the hemoglobin, and in case it is the hemoglobin is maintained, then we can increase the dose to 600 milligram. And most of the time we are able to manage with this 600 milligram. That is what the usual observation has been. However, when you try to increase to 600 milligram of linezolid and you find patient is not tolerating the 6 milligram dose, then we should come back again to 3 milligram. And in these cases, whenever we have to come down to 3 milligram of linezolid, maybe even for last 2 months or 3 months, whatever it is, then in that case, the duration has to be extended and it should be 39 weeks. And please also remember, if in the first 9 weeks of treatment, if due to any reason, any adverse reaction, we have to reduce the dose of linezolid to 300 milligram, it is not permitted, and the regime has to be declared as failure, and patient has to be put on modified all oral longer regimen. So I'm repeating, in the first 2 months or first 9 weeks, we have to ensure that patient is getting the full dose of all the key drugs, that is bedaquiline, linezolid, and predominate. And if you have to give linezolid to 300 milligram, then we have to declare the regime as failed and go on for the all oral longer regimen. Now, regarding the identification of this peripheral neuropathy, it is very, very important that we should be able to identify the early neuropathy, grade 1, grade 2, going on to grade 3 and grade 4. And we need, although there are some the brief neuropathy scales, etc., they are available. But when the guidelines were being framed, it was found that we need simple parameters which can be taught to the nurses, to the peripheral workers. And this table, it is very simple to grade the severity. Like initially the patient will present with numbness, burning, prickly, like pins and needles feeling in the feet. So that is usually grade 1 or grade 2. And also you see very important common symptom is they say when I'm trying to cover my feet with the bed sheet, it feels hurt. There is a little bit of abnormal feeling of this. So even this again is a the neuropathy of, I would say, grade 2. And also if they have cramps in the muscles of the leg or the weakness, again we are dealing with a grade 2. If patient says then I'm unable to distinguish between hot and cold water, or there is worsening of symptoms at night or increase in the leg pain while walking, in that case patient is progressing towards grade 3. And please, I would like to say that in our institute, we were the first one in the country to have started using linezolid way back in 2005 as anti-TB treatment. And that time only one group in Mumbai was using it. Otherwise, we were the first one. And we have given for enough cases. And we burnt our fingers to reach to a conclusion that in these cases, whenever you have neuropathy going on from grade 2 towards grade 3, always stop the treatment early rather than stopping it later. Give it a drug holiday and then try to introduce in the low dosage in case patient can tolerate, not otherwise. I'll come to the next slide of that. Now coming to the next grade 3, grade 4, if the patient complains that there is slipping of the footwear without knowledge, so that means the neuropathy has gone to grade 3, grade 4, that they don't even realize that what they are wearing is falling off. And also they say that I'm not able to put my foot on the ground, so they don't get the feeling that they are putting the feet on the ground. So these are all the indications of grade 4. And also if there is frequent sores or ulcers on the feet, definitely this is a grade 4 neuropathy, and we must ensure to take adequate management of such cases, which I'll come in the next slide. Next slide, please. So whenever a patient of anti-TB medication complains of peripheral neuropathy, the commonest cause is linezolid, and then followed by cycloserine or INS, depending on what drug patient is taking. And we should also remember that the other risk factors like diabetes, very common among TB patients, the low BMI, nutritional deficiencies, HIV, alcoholism, they are also the added risk factors for having peripheral neuropathy. And almost 60 to 70% of the patients who use linezolid in the dose of 6 milligrams, they may develop neuropathy. This we have to keep in mind. Now, how to prevent? Usually, for any anti-TB medication for the MDR-TB, as a prophylaxis, pyridoxine is given. Although the pyridoxine reduces the oxidative stress, but there are some case reports and some studies which show that pyridoxine may not help in preventing the linezolid-induced neuropathy. Next, please. So it is very important, as we discussed in the previous slide, that early recognition of neuropathic symptoms is very important. And in case you have that, we should hold the linezolid for some time. And then we can give a trial of reduced dosages, that is 3 milligram linezolid, and prevent the progression. However, if you find by holding or by reducing the dosage, there is no improvement, and patient may be heading towards from grade to grade 3, please stop the linezolid, do not delay. This is the point I want to highlight because we have seen many cases who progress to grade 3 or even grade 4 by the time they come to us, and the rest of their life they curse to doctors because they have this pain in the leg, they have prickling sensation in the legs, as we discussed earlier. So please do not delay in taking an action. The moment you feel that my patient is slipping from grade 2 to grade 3, better to stop early rather than late, because then patient will have irreversible damage to the nerves. And there can be axonal degeneration from which very difficult to come out. We have seen patients going from one neurologist to another neurologist, and no one is able to give much relief to the patient. And also simultaneously in peripheral neuropathy, we need to take care of the risk factors also, as we have mentioned about like diabetes, nutritional deficiencies. They also need to be corrected. And in case you find patient has peripheral neuropathy symptoms, we have stopped linezolid, but still it is persisting. In that case, we need to consider stopping the cycloserine also. And even if you find even stopping cycloserine is not helping, one may have to consider stopping the INH also. So these things we should keep in mind, that we should not just blame the linezolid. After that, we should also keep in mind the cycloserine or the INH as a cause for the peripheral neuropathy. Next. Now, in case patient has the peripheral neuropathy, especially by linezolid, how should we treat medically? So the medical management of peripheral neuropathy, the common combination which we see, we refer the patient to a neurologist, and gradually over the period of time we have learned that some common drugs they are being used, they should be used because like in most of the TB hospitals in the country or the peripheral clinics, access to neurologists is not there. And or once we are referring to them, it may take 1 week, 2 weeks, 3 weeks to get the appointment. They give time for conducting the nerve conduction study. So all these things, they delay the adequate treatment. So these cases, we can safely start on a combination of pregabalin 75 milligram and methylcobalamin 750 milligram twice a day. And then we can gradually increase the dose if required to pregabalin to say 150 or 300 milligram also. The other drug which can be used is gabapentin, that is on day 1, start with 300 milligram, and then day 2, 300 milligram twice a day, and day 3, 300 milligram thrice a day. Both pregabalin as well as the gabapentin, they have efficacy against the peripheral neuropathy. Only advantage of pregabalin is that it acts faster. Otherwise, they are practically the same. But please remember that in these cases where we are prescribing these medicines, pregabalin or gabapentin, it can cause dizziness and somnolence. So please ask the patient, be careful of whenever they are driving. Rather, better to avoid driving whenever these patients are on this, and we need to counsel the family also about this thing. Also, another medicine which we also give, although this is amitriptyline, which gives relief in the neuralgic pains. We start with the low doses, 25 milligram at the bedtime, and as far as theory goes, it can be increased up to 150 milligram. In my practice, I don't cross 75 milligram or so. But please be remember that bedaquiline has got interaction with amitriptyline, and it can cause serotonin syndrome. So we have to keep that in mind. And if possible, we should avoid giving amitriptyline. Another drug which is available for this is duloxetine. We start with a dose of 20 milligram twice a day for about a month. And if patient gets a relief, we can come down to 20 milligram once a day. If we find that even after starting 20 milligram twice a day, for say about 2 weeks, there is no relief, we can increase the doses to 20 milligram thrice a day. And again, with duloxetine, it should not be given with linezolid, as it can cause serotonin syndrome. So these things we have to keep in mind. And serotonin syndrome, I don't know how many of you have seen it. Even we have seen, I think, only 1 or 2. Here the patient presents with hyperpyrexia, the hypertension. There is the gait of the patient is changed, is very irritable, this patient. And this hyperpyrexia really becomes very difficult to manage. The treatment remains that you stop the drug which is responsible, take care of the this hyperpyrexia, which sometimes can be, you see the mortality is very high in case not detected earlier, that this is because of the drug causing syndrome. And a patient required to be hospitalized, we have to manage the electrolytes, we have to manage the fluids, and that's how we can manage these cases of syndrome. It is uncommon, but please keep in mind whenever we are facing this issue and using the drugs like we already discussed. Again, thank the team from the Madras Medical College to present this case so that we are able to convey to the to our fellow colleagues that which side effects can be there during the treatment and how to manage them effectively without compromising the treatment efficacy. Thank you.
Thank you, Dr. Singla. Are there any questions? So if there are no questions, I think we come to the end of this clinic. We are joined by Dr. Bharadwaj sir. Sir is the chairperson for the National Task Force. Welcome, sir.
Thank you.
Sorry,
Thank you.
I did not see you in the beginning. I just saw you. So I request you to propose vote of thanks for the clinic.
Okay, thank you. Thank you, Nita. Thank you. It was, I could not see the full presentation because I am in Mysore for Zonal Task Force meeting of South Zone 1. So, luckily, the Dr. Sanjay Bhattu was presenting on BPAL regimen. So, but I logged in, so I listened to some of the comments, but I listened full comments by Dr. Rupak Singla. So, it is always I feel fortunate to listen to Dr. Rupak Singla for his wonderful comments. So thank you, and I will mention here that the Madras Medical Colleges, the Institute of Thoracic Medicine, Dr. Vinod Kumar. He's doing a wonderful job in Madras Medical College and along with his team. So thank you, sir. Thank you, Dr. Vinod. So thank you, Dr. Bera, sir, for your expert comments. So I thank everybody, the all participants, though we were less participant. But I take this opportunity to welcome our new DDG, Dr. Shobhini Rajan, and we promise to provide her full support from medical colleges as well as for further programs. So thank you very much. Thank you all. Thank you very much. Thank you, Nita ji. Thank you.
Thank you. Thank you everyone for joining, and we look forward to your feedback, and we look forward to meeting you in our next clinic. Thank you.